Hello, this is a continuation of our lecture on maternal hemorrhagic disorders, which is in chapter 12 of your textbook. During class, we started this chapter, but we stopped after we covered abortion. So we talked about different types of abortion and we talked about the management of abortion. Please do not forget those. So today I'm picking from cervical insufficiency. And this cervical insufficiency is also one of the early pregnancy bleeding disorders. So what is cervical insufficiency? Well, cervical insufficiency is a condition where the lower end of the cervix opens too early during pregnancy. So that is just a common definition of cervical insufficiency. According to the American College of Obstetricians and Gynecologists, cervical insufficiency or incompetence is defined as the inability of the uterine cervix to retain a pregnancy in the second trimester and the absence of uterine contractions. So basically, with this cervical insufficiency or cervical incompetence, the patient experiences passive and painless dilation of the cervix during the second trimester. And so this condition may be either acquired or congenital. So it could be acquired due to damage during difficult birth. So a patient is delivering, she had a difficult delivery, and she ended up acquiring this condition because of the damage that was done to the cervix. It can also be congenital in the sense that this could be due to malformed cervix or uterus from a birth defect. So now, how do you diagnose a patient with cervical insufficiency? Well, diagnosis of this condition is made by the use of speculum or digital pelvic exams. Also, the use of transvaginal ultrasound helps with diagnosis of cervical insufficiency. With this cervical insufficiency too, in order to diagnose it, we could do what is called cervical funneling. So this cervical funneling is defined as a protrusion of amniotic membrane into the cervical os or the cervical opening by greater than 5 millimeters. And this is usually accompanied by short cervical length. So during pregnancy, when a woman is pregnant and her cervical length is less than 25 millimeters or less than 2.2 centimeters, that is a sign that she will have a preterm delivery or she will lose that pregnancy as a result of this condition known as cervical insufficiency. Once again, cervical insufficiency or cervical incompetence is painless dilation of cervix without contraction. So a woman that is experiencing this incompetent cervix will present with advanced effacement of the cervix and dilatation. Also, you may see a bulging or hourglass membrane. So it means that the membrane is actually protruding into the cervix. Backache is also one of the signs. And there are unsure causes of cervical insufficiency such as congenital, hormonal, and also acquired, as we mentioned earlier. Medical therapies for high-risk patients include serial sonograms. So these patients are known as high-risk patients, so they have to be seen more often by the maternal fetal medicine doctors, the high-risk OB doctors. So they have to do serial sonograms on these patients. They need to keep monitoring their cervical length. Also, these patients do benefit from progesterone supplementations and they are placed on antibiotics. We'll talk about this condition, the further management of this condition in the next slide. So the major management of this cervical insufficiency or cervical incompetence is the placement of what is known as cerclage. So this cerclage is basically, there are different types of cerclages. We have the McDonald, we have the Schrocker, we have the abdominal cerclage. So basically, the cerclage is done to help prevent preterm labor or miscarriage with a single stitch placed around the cervix. So the doctors place a single stitch around the mouth of the cervix in order to prevent preterm labor or miscarriage. The first one there is the McDonald procedure. So with this McDonald procedure, a pulse string technique is placed high up in the cervix and then tied close. So if you look at that image on this slide, you will see how this is tied. So usually they use the time, to for guidance in tying this stitch. So they usually start at 12. So a stitch is made at 12 o'clock. They take it to 3 o'clock, down to 6 o'clock, and then to 9 o'clock. Then they tie it now. It goes up to 12 o'clock again, the second time, and it is tied at 12 o'clock. So this is done to prevent preterm delivery or miscarriage. The second one there is the Schrocker procedure. With this, the Schrocker procedure places a submucosal band at the level of the internal os or opening. And the last one is abdominal cerclage, where the band is placed around the cervix through the abdomen. So these are the different types of cerclages. And once again, the cerclage is basically a procedure where a stitch the doctors will place a stitch at the mouth of the cervix in order to close it to prevent preterm delivery or miscarriage. So now, when a patient receives a cerclage, it is very important to know that the patient who is a candidate for this cerclage placement needs to be very, very careful, because cerclage may be placed either prophylactically or as a therapeutic or rescue procedure after cervical change has been identified. So if cerclage is done as prophylactic cerclage, it's usually done around 13 to 14 weeks. So it's usually done around 13 to 14 weeks prophylactically. So now when somebody comes in and they have cervical changes, it could be done around 16, 17 weeks. So when a patient receives a rescue cerclage, you have to make sure that you put them in a Trendelenburg position. And so with a Trendelenburg position, it prevents, pressure from being placed against the cervix. So you want them to be in that position, and they have to be on bed rest. So with this cerclage, once it is placed, and let's say it is placed and it is successful, the patient didn't have any rupture of membrane or they didn't miscarry. So as long as the pregnancy remained, the cerclage should be removed around 36 to 37 weeks of gestation. And so once it's removed, the patient is now allowed to go into labor on their own. And funny enough, sometimes in some patients, we've found out that even when their cerclage is removed, they still stick around till 40 weeks or 39 weeks, which is very, very ironical. But anyway, it's still good for them. So when a woman receives a cerclage placement, they need to make sure that there is a follow-up care. They have to follow up with their OBGYN, their obstetrician. Bed rest, like I mentioned earlier, is very, very essential for a few days following cerclage. They need to watch for and report signs of preterm labor, rupture of membranes, and infection. And this is very, very important. So a woman who has a cerclage in place, if she breaks her water, that cerclage is no longer good. Once she ruptures her membrane, the cerclage would have to come out because of the risk of infection. So that is a very, very important point to remember with regards to cerclage. And also, when a woman has a cerclage in place, you need to tell them that nothing goes into the cervix. They have to be maintained on bed rest. They should not have any sex until the cerclage comes out. So cervical rest means no sex, not even a finger. Nothing goes in there until the cerclage is removed or that pregnancy ended. So now we'll talk about ectopic pregnancy. Ectopic pregnancy is a condition where the fertilized ovum is implanted outside the uterine cavity. It's also known as tubal pregnancies. So when a woman is pregnant, we learned about that last week, that if a woman is pregnant after fertilization, the implantation takes place right inside the uterus and then the fetus continues to develop. However, in ectopic pregnancy, the fertilized ovum, instead of being inside the uterus, is implanted outside the uterine cavity inside the tube. So it doesn't make it into the uterus. And so with this ectopic pregnancy, there are clinical manifestations that the patient will present with. And typically, signs and symptoms will happen around 6 to 8 weeks after the last normal menstrual period. There are three most classic symptoms that are associated with ectopic pregnancy, and these are the hallmark signs of ectopic pregnancy. It includes abdominal pain, delayed menses, and abnormal vaginal bleeding or spotting. So those are your three classic symptoms of ectopic pregnancy. So with regards to the ectopic pregnancy diagnosis, this ectopic pregnancy tend to have difficult differential diagnosis, and this is because of the fact that there are numerous disorders that share similar signs and symptoms. Remember, we talked about abdominal pain as one of the symptoms. So there are other conditions too that patients will present with, and abdominal pain will be one of them. So that's why it is a difficult differential diagnosis. However, quantitative BHCG levels and transvaginal ultrasound examinations or examination do help in the diagnosis of ectopic pregnancy. And also, the progesterone level is considered in order to have the diagnosis. The management of this tubal pregnancy includes medical and surgical management. Under medical management, this drug known as methotrexate is used. And if you remember clearly in earlier, I think we had mentioned it during this the beginning of this course, that methotrexate is a class X medication, and this medication should not be given to women who are pregnant. But in this case, you know that this ectopic pregnancy is not going to survive, so we use this methotrexate. And so methotrexate is a folic acid antagonist that interferes with the proliferation of trophoblastic cells. So that is the mechanism of action of this methotrexate. So now, if methotrexate did not help with this management of ectopic pregnancy, well, the next management level will be surgical. So in terms of your surgical management, a laparoscopic linear sapingostomy is done to gently evacuate the ectopic and also to preserve the tube. Also, we do what is called laparoscopic sapingectomy. And so sapingectomy is the removal of the tube. So just pay attention. Remember the differences between these two. That sapingostomy is the gentle evacuation of the ectopic, and also with that you still preserve the tube. However, in sapingectomy, you are removing the fallopian tube. So the removal of the tube is your sapingectomy. And if a patient had these surgical interventions, or even with the methotrexate after an ectopic pregnancy, there should be a follow-up care. So this patient needs to follow up with a doctor and follow up for continuum of care after this experience of ectopic pregnancy. So this is an image showing what happens in ectopic pregnancy. Well, the next disorder that we need to cover is hydatidiform mole or molar pregnancy. I can't even pronounce this word. It's hydatidiform mole or molar pregnancy. So this molar pregnancy is a type of gestational trophoblastic disease. And so the gestational trophoblastic disease is the pathologic proliferation of trophoblastic cells. And this hydatidiform mole is a benign proliferative growth of the placental trophoblast in which the chorionic villi develop into edematous cystic avascular transparent vesicles that hang in a grape-like cluster. So when you see the picture of a patient who is pregnant with this molar pregnancy, you will see that it looks like a grape-like cluster. When you see the image, it's like a grape-like cluster. And so this is a benign condition, but it can become cancerous, and that is why intervention is very, very important. The incidence of this condition is that it occurs in 1,000 to 1,500 pregnancies in the United States. However, the cause of this molar pregnancy remains unknown. There are two major types of hydatidiform mole pregnancy. One is complete. In a complete molar pregnancy, there is no embryonic or fetal parts. So all you see is that grape-like cluster of that edematous cystic vascular transparent vesicles. In partial molar pregnancy, there is often embryonic or fetal parts, and also you will have an amniotic sac in that partial molar pregnancy. So what are the clinical manifestations of hydatidiform mole pregnancy? Well, the clinical manifestation includes anemia from blood loss. So the patient will become severely anemic, and also excessive nausea and vomiting, known as hyperemesis gravidarum, is a hallmark manifestation of this condition. So that is why when a patient is still vomiting a lot in pregnancy, she has to be ruled out for this molar pregnancy. Abdominal pain or abdominal cramps is also another clinical manifestation of molar pregnancy. In terms of diagnosis, transvaginal ultrasound and serum HCG levels are used for diagnosis. And the care management of this molar pregnancy is with the performance of suction curettage. So suction curettage is used in order to evacuate or to suction out those grape-like clusters in the uterus. And there are nursing managements afterwards. So when a patient has a molar pregnancy, the patient needs to be managed, and of course there will be a follow-up care. It is very, very important to advise a patient who had a molar pregnancy not to get pregnant within 1 year of being treated. So a patient who had a molar pregnancy this 2020 should avoid getting pregnant for a whole year, because if she gets pregnant, chances are that she will end up with another molar pregnancy. So what is the treatment, more treatment of this gestational trophoblastic disease? Well, as we mentioned on the previous slide, suction evacuation and curettage of the uterus is the mainstay, and early evacuation decreases complications. So it is very important that this is diagnosed on time so that the intervention can be implemented early. Uterine stimulation should be avoided with this condition. Careful follow-up for complications, and these complications include anemia, hyperthyroidism, infection, DIC, and this DIC stands for disseminated intravascular coagulopathy or coagulation. So this is actually, we're going to talk more about this DIC towards the end of this lecture. Ovarian cyst is also another complication to watch out for. And of course, trophoblastic embolization of the lung is a very life-threatening complication that can happen. And if this happens, the patient will need a CPR. So you need to start cardiopulmonary resuscitation in this patient, else the patient will die. It is very important too that if a patient had this molar pregnancy, that if she is Rh negative, if her blood type is Rh negative, it is very important that she gets her ROGAM. So that will be part of your nursing intervention to make sure that the patient receives ROGAM within 72-hour window of these procedures. Malignant gestational trophoblastic disease. Or we have this condition known as choriocarcinoma. This choriocarcinoma develops in about 20% of women. So with this condition, it is very malignant, it's very cancerous. So follow-up is very, very essential. The patient needs to have a baseline chest x-ray and repeat x-ray. Also, serial HCG levels need to be done. And if this the HCG plateaus or rises, or if metastasis is detected, the patient will now undergo chemotherapy. So there will be chemotherapy done. Methotrexate is also used alone, or the patient can have a combination therapy because this is cancerous. So that is why you have to make sure that all these are done in order to enhance the chances of survival of this patient, because this can be very, very life-threatening. So now let's get into the late pregnancy bleeding. So all this we talked about the early pregnancy bleeding. So now we will focus on the late pregnancy bleeding. And the first one there is placenta previa. Placenta previa is a condition where the placenta is improperly placed. So this condition, this placental previa has to do with the attachment of placenta, where it is attached. So you have improper implantation of the placenta around the lower segment of the uterus or over the cervix. So pretty much the placenta is covering the cervical opening or the cervical os. Placenta previa can be low-lying, marginal, partial, or complete. In a low-lying placenta, the placenta implanted in lower segments close to the internal os or opening, but not covering it. So it's kind of is implanted around the lower segment. It's not covering it. It's not a total placenta previa. We also have marginal. So with marginal, it's just the edge of the placenta that is close to the cervical os. So the edge of placenta is at the margin of the internal os. Partially covered by the internal os is partially covered by the placenta. However, in total placenta previa, with total placenta previa, the internal opening or the internal os is completely covered by the placenta. So with this condition, it is a very, very is a condition that endangers the patient as well as the unborn fetus. So when a patient has a placenta previa, they usually present with a bright red vaginal bleeding. So they will present with a painless bright red vaginal bleeding. This is why this is in red. So you cannot miss this. It's a painless bright red vaginal bleeding. The cause of this placental previa is unknown. However, there is some association with previous previa, multiparity, increasing age, placental accretor, prior cesarean or other uterine surgery. What do you do when a patient presents with this painless bright red vaginal bleeding? Well, your intervention should include no vaginal exams. So you need to keep your hands to your pocket. No vaginal exams. You need to confirm the source of this bleeding by using ultrasound. So the confirmation of this diagnosis of placental previa is done via ultrasound. So patient comes in bleeding. Do not put your finger inside of the vagina until you have confirmed the placement of the placenta. Because we say that the placenta, it could be a total placental previa where the placenta is covering the internal os. So if you try to do a vaginal exam, just picture it. If you're trying to do a vaginal exam on this patient, you could end up damaging the placenta because that's where your finger is going to touch. And if you damage the placenta, you will cause catastrophe. You can kill a patient and also her unborn fetus. So no vaginal exam until confirmation of diagnosis is done via ultrasound. It is very important to monitor vaginal bleeding, pain and uterine contractions, which can also be a sign of impending placental abruption. monitor vital signs. Fetal heart rate has to be monitored continuously. Now you need to establish an IV access. Also, the patient needs to have an IV access. Complete lab work is done, type and cross-matched for 2 to 4 units of red blood cells. So this patient is at risk for deficient fluid volume, excessive blood loss, and ineffective tissue perfusion related to blood loss, uterine atony as well. And of course, you have the diagnosis of anxiety due to the fear of unknown. So the patient is at risk for hemorrhage. You need to make sure or hypovolemia, I should say. So you need to make sure that the patient, when you are establishing an IV access, that you use a large bore angiocath. Usually we start an IV using the 18 or 16 gauge needle. So this is very essential because you know that this woman is at risk for fluid volume deficit or excessive blood loss. So you want to use those needle gauge in order to start the IV because you anticipate that this is a patient who may need blood transfusion. So you only transfuse a patient with large bore needles and not small needles. So in order for you to remember the symptoms of this placenta previa, you may want to remember the mnemonic previa, P-R-E-V-I-A. A P stands for painless bright red bleeding. So that painless bright red vaginal bleeding. R, relaxed, soft, non-tender uterus. So the uterus is non-tender, is soft, so there is no pain. E, episodes of bleeding. So this patient will have episodes of bleeding. V, there will be visible bleeding. So the bleeding is not concealed in placenta previa. You will see the bleeding. I stands for intercourse post-bleeding. So we call it postcoital bleed. So when a patient who has previa have intercourse, she will bleed. And that is why one of the interventions will be for them not to have intercourse because of the risk of bleeding. And A is abnormal fetal position. So usually when somebody has a placenta previa, the fetus will be in a breech presentation. Because if you just picture it, if the placenta is covering the cervical opening, will the head of the fetus be on top of the placenta? So usually the fetus will assume a malformation. So you may have a baby that is in a breech presentation because the head cannot go down because the placenta has already occupied that space. The incidence of this placenta previa is 1 in 200 pregnancies. So what are some of the maternal and fetal outcomes? Well, there is a major complication of hemorrhage. Fetal death could be caused as a result of preterm birth. Stillbirth is a complication or an outcome for the fetus. So you may have stillbirth, malpresentation, as I mentioned, fetal anemia, intrauterine growth restriction or IUGR, and the care management, expectant management, and we already talked about the interventions in the prior slide. Home care, so if it's a patient who has a marginal previa or total or partial previa, usually they will be monitored and they will be, they will tell the patient to be doing monitoring at home. If the patient is bleeding, she needs to go to the emergency room right away. So also sometimes they will send this home care nurses to home to see the patients to see how they're doing. And if they are really hemorrhaging, then you need the active management. So that is a picture of the placenta previa. So in this one, you see the first picture is a picture of a complete or total placental previa. You see how the placenta is just covering the cervical os. And over here is a marginal or partial, and usually this will resolve sometimes. Most times this is diagnosed around 20 weeks and slowly it will move away. So the problem with this, once again, is that the placenta is the placement. It has to do with the placement where the placenta attaches itself to. It is just the location where it is. The placenta is still adhering to the uterine wall, but it's just the placement where it is located. That's the major problem with this placental previa. So now this is the opposite of placental previa. We have what is called abruptio placenta. So this abruptio placenta, unlike the placental previa, this abruptio placenta is a condition where the placenta prematurely separates from normal implanted position. So usually after fertilization, implantation, you have the placenta placenta develops and then attaches itself to the uterine wall. After delivery, the placenta naturally will separate. However, in the setting of abruptio placenta, the placenta prematurely separates. So when this happens, so when you have that detachment, a premature detachment or separation of the placenta from the uterine wall, that is an obstetrical emergency. Earlier, we said that the placenta is what feeds, that the fetus gets its nutrients, oxygenation from mom through the placenta via the umbilical cord. So now, if the placenta separates or detaches prematurely, will the fetus be getting oxygenation and nutrients? Absolutely not. So that becomes an obstetrical emergency. You can have a dead baby and mom can go into DIC with this condition. So let's talk about the symptoms or the signs and symptoms of this placental abruption. So the signs and symptoms include pain, rigid abdomen, vaginal bleeding, uterine irritability. And with regards to the vaginal bleeding in placental abruption, this vaginal bleeding is usually dark red blood. So this is a dark red vaginal bleeding that you will see in placental abruption. In placental previa, it will be bright red vaginal bleeding. In this abruptio placentae, it will be dark red vaginal bleeding. And sometimes you may not even see any bleeding because the bleeding is concealed. It is inside the uterus. So these are the symptoms, and this condition happens in 1% of all pregnancies and about 15% of perinatal mortality. There are 3 types of abruptio placenta. We have marginal. With marginal or abruptio or placental abruption, there is a partial separation. So you have partial separation. You may have vaginal bleeding or not. There will also be tenderness. We have the central or complete placental abruption. Now with this, there is concealed bleeding and there is extreme abdominal tenderness, total separation of the placenta. The abdomen is very rigid, or we call it board-like abdomen. So when you hear board-like abdomen, think about a table, and if you go like this on a table, how hard it is. So that board-like abdomen is a hallmark sign of placental abruption. And of course, you have increasing size of the fundal height. So this condition usually happens in the 3rd trimester. So if a woman will abrupt, it will be around the 3rd trimester. In order to remember the signs and symptoms of this placental abruption, remember this word detached, or the mnemonic detached. So detached, D stands for dark red bleeding or dark red vaginal bleeding. E for extended fundal height. So it means that the fundal height is increasing because of the bleeding, and this is due to the concealed bleed. T for tender uterus. So the uterus is very tender. A for abdominal pain. C for concealed bleeding. H, hard abdomen. So that's that board-like abdomen. E for experienced DIC. So this patient who is abrupting will experience DIC if proper management is not implemented. And D stands for distress fetus or baby. So the baby will have a fetal deceleration, the heart rate will drop because this fetus is no longer getting its nutrients and oxygenation. So that's how you remember the signs and symptoms of abruptio placenta, remembering the mnemonic detached. So usually with this condition, there are classifications. We use this classification system, grades 1, which is usually mild, about 10 to 20%, and grades 2, moderate, 20 to 30%. And if it's grade 3, it means that it's severe, it's greater than 50%. So why is it that this patient may experience DIC, as I mentioned earlier? So basically, when placenta detaches itself, it can damage and release large amounts of thromboplastin into mom's circulation. And so with this release of this thromboplastin into mom's circulation, this will now set off a massive clotting event throughout the body, and it will cause small microembolism to form in the blood. So you have formation of small microembolism in the blood. So with this formation of this microembolism in the blood, this is going to now block blood supplies or blood vessels. It will block blood vessels and also block blood flow. It can affect major organs like the brain, the kidneys, and the lungs. Also, during this cascade of events, as the body senses this major clotting event going on, now the body tries to help. And so how does the body try to help? Well, it tries to help it by causing fibrinolysis to happen, hoping that it will help to break up the clot. But the issue now is that with this, at this point, the patient has now, the clotting factors are already depleted because this patient has been bleeding. So the clotting factors are already depleted. So it's not going to do the normal job that it's supposed to do to stop the bleeding. So hence the patient will bleed out. And so that is why this DIC is a very, very threatening condition that can happen as a result of placental abruption. So once again, the placental abruption is the premature separation of the placenta. And when that happens, another name for this is actually cuvulae uterus. So it means that the placenta has prematurely separated. It's a detachment of part or all of the placenta from implantation site after 20 weeks of gestation. So let's talk about the risk factors. What are some of the risk factors that predispose a woman to having abruptio placenta? Maternal hypertension is a primary risk factor. If you remember, I think one of your case studies about a patient who had preeclampsia, so you saw some of those assessment questions that the nurse was asking how it relates to abruptio placenta. So maternal hypertension is a primary risk factor for placental abruption. There are also greater frequency noted in patients who are smokers, patients who prematurely rupture their membrane. So PROM stands for premature rupture of membrane. You have greater frequency with multiple gestation, advanced maternal age moms. Cocaine use. Patients who use cocaine, we see this a lot in patients who use cocaine. Chorioamnionitis, and this is the infection of the chorion and the amnion. And once again, you have that hypertension. So these are a greater frequency of occurrence with all these that are outlined here. Other causes includes domestic violence, trauma to abdomen, so abdominal trauma, fibroids, fetal growth restriction, short cord, and high parity. So if a patient has a trauma, abdominal trauma, a patient who fell, a patient whose FOB kicked on the belly, or somebody kicked the patient on the belly, anytime you have a trauma, you have to rule the patient out for placental abruption. domestic violence, all those things, these are causes of placental abruption. Very life-threatening condition that can happen. And when that happens, it becomes an obstetrical emergency. So this is a picture of that, the placental abruption. So in the one on my left, on top left, is a picture of partial separation. So with that, you still have the concealed hemorrhage. So you have the bleeding behind the placenta, and also you may have apparent hemorrhage. So if it's apparent, you will have that dark red vaginal bleeding. If it's concealed, there is nothing coming out. The patient will be bleeding internally. And the last picture at the bottom is a complete separation, and that is more severe. Other disorders that fall under these conditions include cord insertion and placental variations. So there are different conditions that fall under this category. We have what is called vasoprevia. This condition is where fetal vessels lie over the cervical opening or the cervical os, and the vessels are implanted into the fetal membranes rather than into the placenta. We have the filamentous insertion of the cord, where cord vessels branch at membranes and then onto placenta. These are the major ones out there. Just don't worry about the other two. These are the images. Clotting disorders in pregnancy. Well, normally our body there is a normal clotting system in our body, and under normal circumstance, a delicate balance exists between the opposing hemostatic and fibrinolytic systems in our body, and that is called homeostasis. So our body loves homeostasis. We also have a hemostatic system, and the role of this hemostatic system is to stop flow of blood from injured vessel. So when there is injured vessel, the hemostatic system will come into play. It will stop the flow of blood from that injured vessels. We also have normal platelet clot formation, fibrin clot formation, and the cascade effect that takes, that plays a huge role in our body. Our body also we have the fibrinolytic system, and this fibrinolytic system is a process through which fibrin is split into fibrinolytic degradation products and circulation is restored. So this is what happens under normal circumstances when there is no clotting disorder. However, when there is clotting disorders in pregnancy, and one of the hallmark clotting disorders in pregnancy is known as DIC, and the DIC stands for disseminated intravascular coagulation. So that's a major clotting problem. It's a major clotting disorder, and this DIC is a pathologic form of diffuse clotting that consumes large amounts of clotting factors, causing widespread external bleeding, internal bleeding, or both. DIC is never a primary diagnosis. So nobody comes in and is diagnosed with DIC as the primary diagnosis. No, rather it results or it is a diagnosis which results from other acute or traumatic events. So somebody can go into DIC as a result of severe hemorrhage or a placental abruption which led to hemorrhage. So it's never a primary diagnosis. The care management and nursing intervention of these DIC solely relies on correcting the underlying cause. So whatever is the underlying cause of the DIC needs to be corrected. And DIC could happen as a result of abruption, as I mentioned earlier, HELP, and HELP stands for hemolysis, elevated liver enzymes, and low platelets. And also it could be as a result of severe preeclampsia and anaphylactoid syndrome, postpartum hemorrhage with other clotting problems. So these are some of the causes of DIC. So in the setting of any of these, correcting the underlying cause will be the mainstay in order to treat the patient. And of course, massive transfusion protocol needs to be activated when a patient is in DIC, because you really need to give massive transfusion of fresh frozen plasma in order to help the patient, as well as platelets. Placental accretor. This is another obstetrical emergency. So all these things we've been covering so far is an obstetrical emergency. We talked about placenta previa, placental abruption. Now this one is placental accretor. These are all obstetrical emergency. So this placental accretor is is a condition when chorionic villi attach directly to the myometrium of the uterus, and this is the most common type of placental accretors. So when a patient has an accretor, it means that the chorionic villi have attached directly to the myometrium of the uterus. Adherence may be total, partial, or focal, and this usually happens in 1 in 2,500 births. Another placental accretor is what is known as placental incretor, and this is when the myometrium is invaded. There is also placental procretor. With procretor, the myometrium is penetrated, and the treatment of any of these placental problems, any placental accretor, either accretor, incretor, or procretor, the treatment is doing what is known as IR. And IR is interventional radiology. So the patient will go to IR in order for them to take care of this. This is a patient who will be delivered in the main OR. And also hysterectomy will be another treatment, because if this attaches to the myometrium or invaded the myometrium, there's no way you can separate it other than to remove the uterus. So interventional radiology and hysterectomy are the mainstay of placental accretor problems. The question here, I think I have to say this because there is an error on the PowerPoint. I think the answer that was given on the PowerPoint, that's a mistake. This question says, in caring for an immediate postpartum woman, you note petechia and oozing from her IV site. You monitor her closely for which clotting disorder. So I think the answer that was given on your PowerPoint says A. It is not amniotic fluid embolism. The answer is D. It is disseminated intravascular coagulation, DIC. So this diagnosis is based on clinical findings and lab markers. When you look at the question, the patient has already the patient is experiencing unusual bleeding. The patient has petechia and oozing from the IV site. So those are typical signs of DIC. And that is the end. So I will be forwarding you a study guide for this upcoming exam on Wednesday. With this exam, I will not add sexually transmitted diseases to it, and also I will not add use of drugs and substances. So that will be I will save that for your second exam. So that is it. I'll see you next week.